I'm Matthew Weinstock with Hospitals and Health Networks, reporting to you live from San Diego, where nearly 2,000 healthcare officials are gathered for the Health Forum American Hospital Association Leadership Summit. With me now is Rich Umbdenstock, President and CEO of the AHA. Rich, thanks for being with me.
My pleasure, Matthew.
So, Rich, you're finishing up the AHA board meetings here before the summit kicks off a little bit later this afternoon. Can you give us a sense of what the conversations are like with the board right now, how folks are feeling about the pace of change in the industry?
Well, overall, the board's very optimistic. We see all kinds of signs that the field is making the adjustments that are necessary to live with less payment, improve quality and safety, patient satisfaction. Terrific work going on. We're all a little confused about what's happening in D.C. because not much is happening, and we're expecting things to kind of come to a boil at the end of the year, another so-called cliff or set of cliffs, which is unfortunate. But that's not stopping the progress that's going on in the field. So the board's very pleased and really proud of what the membership is doing.
So as you referenced DC, if we can stick on that for a second, there's legislation moving forward that would do the doctor fix, the so-called doctor fix. Obviously, the devil is in the details on that, but what's your sense of what that's going to look like and what it may mean for the field if that moves forward?
Well, it really does seem to be getting some traction this time around, but it's still early. It's at the committee level and subcommittee level. I think everybody would love to see it fixed. Our continuing concern is how to pay for it. And in the past, they've come after hospital payments to pay for this physician payment fix, which is really silly, especially when you think about how many physicians now work for hospitals. So it's more of an accounting exercise than a true fix in the payment system. But it does seem to be focused on more of a comprehensive fix this time rather than a patch. And again, we expect it to be all tied up in the end of the year, fiscal negotiations, debt ceiling, budget, and so on.
So a lot of wait and see on the policy front.
Yeah, definitely.
So we also, out of the DC realm, had 9 organizations that announced they were not going to continue with the Pioneer ACO project. I'm wondering what kind of message you think that sends to federal partners and the marketplace in terms of the field's readiness to adapt to these new models, or was it unique to the Pioneer ACO?
Well, I think it sends exactly the right message, which is we're learning. These were set up as demonstrations. Nobody knew that you could do, whether or not you could do an integrated delivery system approach on a non-integrated chassis. And so we went into test mode and we're testing. For many of them, they looked at this as way too much work and complexity. In another case, one dropped out entirely because they were already low cost, low utilization, didn't see the benefit going down the road, happened to also offer a Medicare Advantage plan. So they just saw a different route and a better route. So we're learning. We can focus a lot on the Medicare experiments, but we also have to keep in mind there's an awful lot going on with commercial payers. So I think overall, this is terrific. We're learning, but it's not all going to be a straight line.
One of the other themes that is going to be talked about here at the summit for the next 3 days is population health. Can you give a sense of how the field is moving towards that continuum of care and improving health for their communities?
Yeah, when you think about population health, you definitely have to put the emphasis on health, on less utilization, earlier interventions, coordination of care. Hospitals are working on all of those things for a lot of reasons, whether it's the current penalties under hospital-associated conditions or readmissions. Those are all elements that will lead to the capability to manage the health of the population. There'll be a lot of challenges in that as well as we think about truly capitated payments or really fixed payments and so on. There'll be a lot more learning, but the field is already moving in that direction. So I think we're making good progress.
And do you get the sense that the hospital community is moving at the same pace as the payer community on whether it's new payment models or population health issues?
I don't want to be the cynic in the crowd, but I think the payer community would love to get out of the risk game. They've been trying to do that for a long time and put it on to providers. I think the good news is that providers are stepping up, but they're doing it cautiously, not recklessly. So people are starting to move in that direction. There's a lot of good payer-provider partnerships going on to move together in this direction. But yeah, I think the payers would love to have been there yesterday. But if we'd known how to do this, I think everybody would have put it into the Affordable Care Act. But instead, we're taking it in steps, which is the right way to go.
And you referenced learning a few minutes ago. This meeting is all about learning between peer-to-peer learning. As you think about that, what kind of skills gaps or skill opportunities exist for hospital executives now, as we move towards these new models of care? What things do the C-suite need to pick up?
Well, certainly, I think we've made huge strides in the quality, safety, satisfaction realm, and that's going to be key under any payment system. So I'm really proud about that. Cost reduction is showing itself now in the data. Lowest rate of increase in years, hospital costs really moderating significantly. When you get into a fixed payment environment, care for a population, that's huge. I think the thing that is probably the biggest gap is the risk issue, and how do we truly manage financial risk, and what actuarial capabilities do we need? How does that change your executive team composition? How does it change your board committees and board oversight? And then just the actual function of it, which is why I think it's good that a lot of people are partnering with payers, because payers have that expertise. They don't have the delivery of care expertise. So that's a good thing. And then the more we learn about coordinating care across the continuum, the better we'll be.
There was a AHA town hall earlier here at the summit, and that'll be rebroadcast for members to view. What were some of the themes that we're going to come across in that town hall, and why should members be viewing into that?
It's all about coverage and enrollment now. We're headed toward October the 1st when enrollment starts to open up, January 1st when coverage starts to kick in. One of the big challenges is how will we actually identify, inform, communicate with, and motivate people to get enrollment. Very important to hospitals because of the cuts that we've agreed to in exchange for, helping to pay for enrollment. So this is all about what hospitals need to know about helping people get enrolled. I hope members saw our member advisory that we sent out earlier this week on all of the tools and assets that we're providing to help them in that role. And it was a terrific overview from Marilyn Tavener and others about what to expect.
On that enrollment front, the administration obviously pushed back the employer mandate in the Affordable Care Act. That I imagine is some frustration for the hospital field. Yeah,
we were very disappointed. Didn't know it was coming, and it effectively takes away a projected 2 million to 2.5 million people with coverage because of the delay. They were expecting about that many people under that particular provision. Some said not a big number. We think it's a big number. And I think if you're one of those 2 million, you think it's a big number and a big development. But when you put it together with the voluntary expansion of Medicaid, maybe a slower than expected start for the exchanges, the cumulative impact is very troubling, that we're not going to get as close to those enrollment numbers as originally projected. That's not good for people without coverage, not good for providers providing care to people without coverage.
And it's got to make it hard for providers to really plan and know what their financial and strategic plan may be going forward, right?
Yeah. I think the only thing that people can do and people are doing is to know that some of those reductions are kicking in. We're going to try to push off the DSH cuts for a couple of years and have legislation and need member support to promote that legislation to do that. But they'll know that the reductions are here. I don't know that a lot of people are planning on a lot of increase in coverage, so that it'll only be good news in that sense, which I think is the prudent way to go into next year's budget. I know a lot of people are doing that.
And lastly, Rich, we've got a pretty stellar lineup of keynote speakers here at the summit. So Dr. Berwick will kick things off today at about 1 o'clock California time. Irvin Magic Johnson's here. Right. Is there anything that is really piquing your interest that you're really wishing to see?
Well, I have to admit, I'm as excited as everybody about Magic Johnson. He's quite a charismatic leader. But, he obviously has his own story to tell on the healthcare front, and he's a hugely successful business person from a very important segment of our population, the minority community. So I think he's got a lot to share, other than I'm sure some really good basketball stories. But overall, this meeting picks a bunch of leading figures, and it's not all healthcare. We look for the historical context, and we look for the economic context, where the country's headed, and so on. And so I think it enriches the overall program. But then in those breakout sessions, people get right down to to hard knocks there in terms of actual healthcare subjects, and we got some great tracks, educational tracks lined up.
Right. Well, great. Rich, I appreciate your time here today.
My pleasure, always.
And so I'm Matthew Weinstock, reporting from the AHA Health Forum Leadership Summit in San Diego. We'll have more reports in Friday and Monday's H&HN Daily. Thanks for tuning in.